Here's a detailed expansion of each section on neonatal hypoglycemia, including case correlation and rationale. Etiology. Maternal factors. Diabetes in pregnancy. Poorly controlled maternal diabetes, gestational or pre-existing, increases fetal glucose exposure. Chronic maternal hyperglycemia causes fetal pancreas hypertrophy and hyperinsulinemia. Case link. Baby X's mother had gestational diabetes, which likely led to fetal hyperinsulinemia. Intrapartum factors. Stressful labor or delivery can lead to asphyxia, increasing neonatal metabolic demands. Delayed or insufficient feeding after delivery exacerbates hypoglycemia risk. Fetal neonatal factors. Prematurity. Preterm infants have reduced glycogen stores, immature gluconeogenic enzymes, and increased metabolic needs. Intrauterine growth restriction, IUGR. Small for gestational age SGA infants have limited energy reserves. Macrosomia. Large for gestational age, LGA babies often experience hyperinsulinemia due to maternal hyperglycemia. Case link. Baby X, weighing 3.8 kilograms, was LGA and predisposed to hypoglycemia. Iatrogenic causes. Delayed feeding. Newborns rely on external glucose within hours after birth. Any feeding delay can precipitate hypoglycemia. Excessive insulin therapy occurs when treating maternal diabetes in utero or in neonatal care. Rationale. Understanding these factors aids in identifying at-risk newborns early, enabling preventive care. Pathophysiology. Fetal glucose metabolism. During pregnancy, glucose crosses the placenta freely, but insulin does not. High maternal glucose causes fetal hyperglycemia, stimulating the fetal pancreas to produce insulin. Post-birth transition. After birth, maternal glucose supply stops abruptly. Persistently high insulin levels, due to fetal programming, lead to rapid glucose utilization and hypoglycemia. Preterm or SGA babies lack adequate glycogen and fat stores, worsening the problem. Key systems affected. Brain. Glucose is the primary energy source for the brain. Prolonged hypoglycemia can cause irreversible brain damage. Liver. Inadequate glycogenolysis and gluconeogenesis due to enzyme immaturity. Rationale. A clear understanding of pathophysiology explains why some neonates are more susceptible and helps in planning treatment. 3. Clinical manifestations. Early signs. Jitteriness or tremors due to increased sympathetic activity. Poor feeding reflects systemic energy deficit. Hypotonia, reduced muscle tone, indicates poor energy supply to muscles. Moderate signs. Cyanosis suggests peripheral circulatory compromise. Lethargy, decreased alertness due to low brain glucose. Severe signs, seizures, indicative of critical brain hypoglycemia. Apnea or bradycardia, result from impaired central nervous system regulation. Case example. Baby X presented with jitteriness and lethargy, classical early signs of hypoglycemia. Prompt intervention prevented progression to seizures or apnea. Rationale. Recognizing subtle signs prevents escalation to severe symptoms. 4. Diagnosis, initial screening, bedside glucose test, heel stick test for immediate blood glucose measurement. Normal range 40 milligrams per liter in the first 48 hours, 50 milligrams per liter thereafter. Confirmatory tests, laboratory glucose, more accurate than bedside methods. Critical sample analysis, drawn before treatment to identify underlying causes. Insulin, elevated in hyperinsulinemia. Ketones, absent in hyperinsulinemic states. Cortisol and growth hormone, to rule out adrenal or pituitary deficiencies. Case example. Baby X's heel stick glucose was 30 milligrams per deciliters, confirming hypoglycemia. No ketones were detected, supporting hyperinsulinemia as the cause. Rationale. Accurate diagnosis differentiates transient hypoglycemia from conditions requiring long-term management. 5. Management. Immediate steps. 1. Feeding. Initiate breastfeeding or formula within the first hour of life. If feeding is ineffective, administer expressed breast milk or formula via gavage. Case link. Baby X's poor feeding necessitated IV intervention. 2. IV glucose, bolus, 10% dextrose, 2 millimeters per kilograms, for rapid glucose correction. Continuous infusion, 6 to 8 milligram kilogram min to stabilize glucose levels. 3. Frequent monitoring, check blood glucose every 30 minutes until stable. Long-term steps. Treat underlying causes, e.g. maternal diabetes, sepsis, or hormonal deficiencies. Gradually taper IV glucose while increasing enteral feeds. Rationale. Aggressive but controlled intervention ensures glucose stability while avoiding rebound hypoglycemia. 6. Acute complications, seizures, apnea, cardiac arrest. Failure to recognize symptoms early can lead to catastrophic outcomes, chronic complications, neurological impairments, delayed milestones, developmental delays, or cerebral palsy. Learning disabilities due to early brain energy deprivation. Case correlation. Baby X avoided complications due to timely intervention and glucose stabilization within 6 hours. Rationale, highlighting complications, emphasizes the importance of early detection and management. 7. Prognosis. Favorable outcomes. Most neonates with transient hypoglycemia recover fully if treated promptly. Poor outcomes. Prolonged hypoglycemia, 1 hour, increases the risk of brain injury. Recurrent hypoglycemia may indicate underlying metabolic or endocrine issues. CaseLink, Baby X's prompt treatment led to discharge within 48 hours, demonstrating excellent prognosis for transient neonatal hypoglycemia. Rationale, prognosis reassures caregivers and emphasizes the significance of early interventions. Case analysis and conclusion summary of Baby X's case. Maternal gestational diabetes caused fetal hyperinsulinemia, delayed feeding exacerbated neonatal hypoglycemia, early IV glucose bolus and continuous infusion corrected hypoglycemia quickly, preventing complications. Key learnings from the case. Screening at-risk neonates, e.g. LGA, diabetic mothers, is essential. Early feeding and monitoring can prevent most cases of neonatal hypoglycemia. Final takeaway. Neonatal hypoglycemia is a manageable condition with early recognition, appropriate treatment, and consistent follow-up. If you found this video helpful, don't forget to give it a thumbs up. Subscribe to Skeletal Evolution. Hit the bell icon so you never miss an update. Got questions or topic requests? Drop them in the comments below.